screen is coming here. And again,
Yeah.
I apologize. I actually logged in when I was. Um, what I listened to a couple of talks, really excellent talks that I would like to talking about the challenges and the new frontiers that we see in full endoscopic spine surgery here. And again, thanks for including me, and sorry for the delay. Disclosures, for this relevant, to do a lot of teaching for Choimax, and I also do a lot of teaching for the AO spine, which is not associated with Choimax. But that's my relevant. I'm sure this has been addressed earlier, but the big question is always, when you have new trainees else, why should you at all do this? I mean, new equipment, new technique. And I always find it astonishing that, the answers really with the traditional open surgeons here with Dr. Jens Chapman, who is just an amazing, brilliant opens it, what determines complications. And they looked at cardiac, pulmonary, GI, neurological, hematological, urological complex, laundry list.
We've lost your link, Dr. Hofstetter.
Am I back up?
Yes.
Can you guys see my screen now? Can you
Yes,
see my
but
screen?
Yeah, we can see you
Hello?
now.
yes,
Yeah.
but sound is
Okay, I
crackling.
don't know what this is. Sound is not good. Yeah, I'm sorry. It's just
Now it's good.
a very poor connection here. I apologize. This is not.
Okay.
Not great. Okay, so I think again, this is one of the main issues that I think needs to be addressed. And then the other thing is, I think that is important is we wrote a paper last year, as we call it, the benefit zone of endoscopic spine surgery, where we look at what is the sweet spot of this technology. And certainly, discectomy is a relatively low complexity procedure, and accordingly, the additional benefit of lower complications with endoscopic spine surgery is there, but it's not it's not tremendously big. So, but it's like, complication rates, as we know, all the outcomes should be very similar. But the complication rate goes roughly down by 3% if you look at all the randomized prospective controlled trials. And that changes quite dramatically when we look at now something that is more, complex. And there were a couple of talks today on the agenda. When we look at, for example, an over-the-top decompression surgery, where with traditional surgery, we have 30% complications, endoscopic, we have 9% complications. So there's going to be certain procedures where there's a tremendous potential. And I would almost say that, for example, a thoracic discectomy is right in the beef of this, right in the middle area. Because that's where you have the biggest bang for your buck. And so, but on the other hand, you also see that those, curves cross again. So there's going to be areas where we try to push the limit and really we don't give the patient any additional benefit. And the same has been true in MIS, where certain procedures have been done that really push it too far, and then there's no more benefit to the patient. But it's up to us to define that area where endoscopic spine surgery has clear benefits. and that gets me to the next sort of talk. What's really important to push the limits and to move along is having cutting edge technology. And I'll just show a couple of examples there. As we talked about endoscopes, we talked about the working channels right now, for the interlaminar approach, I totally agree. I think more than, less than 4 millimeters is too small. It's really difficult to do any meaningful work. For the transforaminal, 3.7 millimeters is on the smaller side, but you can accomplish a lot. And you can see I even have an example of a partial corpectomy that I would like to share afterwards. Drills are really important in that for bone removal, and there's different technologies and different companies making this. But learning how to do that and efficiently remove bone is a skill that everybody in this audience probably has mastered. And again, for the interlaminar technique, when I teach the residents and fellows, is really to follow that yellow ligament attachment that actually we made, the principal anatomical landmark for a reason. Is as long as you follow this attachment, and you see it up here, you really don't get lost. The second you don't drill along that attachment, it's very difficult to be efficient. Navigation is another new thing that is coming out, and people have used different navigation systems. Now there's one, Germax has brought out a navigation system that is designed only for endoscopic stuff. And I think there's a tremendous role for that, in that, it's going, these systems are going to help us surgeons to remove, some of that radiation exposure that we all have. And as you know, there's papers floating around that the rate of cancer in spine surgeons is, almost, 10 to 15% higher than that of other surgeons. So I think that's even, though that's at the very beginning, and it works, but it's something that all of us should be interested in to get ourselves out of the radiation, which we are constantly exposed. And I think once we have that more broadly implemented, I think it's going to help us to flatten the curve, the teaching curve, the learning curve. There have been some talks before talking about, how difficult it is to learn that and how long it takes. And I think having navigation and knowing exactly where you are all the time flattens that curve, and especially the radiation exposure. And again, everybody doing these procedures, I think we all have to kind of think about how we can improve that, because that's going to be not sustainable. It's really useful for posterior cervical foraminotomies, especially at the lower levels where it's very difficult to determine the level. For transforaminal approaches, and especially for the fusions, where you can then also use the navigation to put in pedicle screws. That is another frontier that is coming. I think the next big thing is going to be endoscopic fusions. And the issue with endoscopic fusions, it really needs a highly orchestrated array of instruments and devices. So you're going to need navigation. You need to do a very nice foraminotomy, foraminoplasty, the discectomy, and then innovative graft design. And there's some new challenges and new sort of developments there, especially the 3-dimensional expandable cages that look very promising. Also the two portal systems I think are very interesting. So I think there's some technology coming there that I have no doubt that in 5 to 10 years we'll be able to compare those favorably with MIS TLIFs. It's right now just at the breaking point. So I do maybe like 20 a year when there's really no other, when I can't do an MIS TLIF, but it's certainly technically possible, as you can see there. And then those little things, we did this little, in the Germax set, we have designed this little plastic holder. It's blue, and it looks very silly. But this thing helps you to get your hand out of the C-arm. You can hold all the dilators and nobody knows what it's for. So this is the lowest low-tech thing in the world. You could probably print it yourself in your shop or make it out of a piece of a stick. It can hold the dilators during the whole procedure, but it helps you to get your hand out of the beam. And nobody knows what it is for. So that's why I put it on there. It's really low-tech, cheap, and it helps. And again, it's a really very little brilliant sort of little thing. Then obviously you want to have a tower and the different systems, that have complete systems. And again, I work with different systems. I work with Wolf and with Joymax. They've really sort of pushed it forward. But again, enough of different company stuff. One other thing that we have worked on is the nomenclature of surgical procedures, and I would like to invite you to really utilize it. I've had the great honor to work with the best experts worldwide, and you can see the author list there, and we designed and some of them I think I saw on the list here too. So thanks everyone who contributed. During a year of back and forward, we designed an AOS, as an AO, we call it the AO spine, a consensus paper on nomenclature. We looked at the approach, the instrument, the location of the procedure, and designed this nomenclature system. And you can see here the whole list that is throughout. The nice thing is, as long as we reference to this, is that you can now find your work, because as you see, if you're looking for a paper on, for example, transfemoral discectomy, you're not going to find it. People call it PELT, people call it whatever they call it. And I called it differently too. I mean, a lot of people say that, I used to call it like this. Well, I have papers too that I called it differently, but I think at some point we have to agree on one way to call it. And I would everybody encourage to use this new nomenclature system, because then people can find your work. If you do good papers and publish them and you don't use a nomenclature system that we agree upon, nobody's going to reference and honor your work. So again, 28 experts worldwide, and this is what we came out. So again, thanks everyone for helping with this. I think this is going to really put our field on much stronger legs. And then two, I don't want to take too much of your time. Then I have two examples that I think that sort of really show the new frontiers, and where endoscopic spine surgery is really hitting the biggest area of this benefit zone. One of this is what we call the endoscopic, cervical endoscopic unilateral laminotomy for decompression. And again, I've published a book on that, and during that work, really that principle of target area and principal anatomical landmark came very clear at the end of working on this for a year. A target area is a bone area, like a structure on the bone that you can see on the X-ray, you can palpate with your needle or with your trocar, and that you can visualize. That is nothing that has anything to do with anybody sort of pushing down the throat, any procedures or anything else. But as you can see, next time you do your procedure, you will have a target area that you can see on the X-ray, that you can feel, and that you can visualize. And then the principal anatomical landmark, for example, for this procedure is the ligament attachment, because it guides you safely towards the neural structures. Everybody uses that. It's just, for me, there was a revelation to kind of use this now for teaching. And you can see when you're standing behind a fellow and they're kind of totally lost, you're like, what are you doing in the middle of the spinous process base? That's typically where you get lost into lamina. And then, so that's typically how you can get them back. Quick here, we've sure seen that. So that's kind of the target area for our approaches, is the edges of the lamina and the cervical work. Because you can see it easily, you can see it on X-ray. Then we do the bone work along the attachment of the L ligament, as you can see there. Here's the lamina, and the L ligament attachment is right there. Hemilaminotomy. One thing in the cervical spine, when you do complete decompressions, there is not in the lumbar spine, you can get away with taking not as much from the base of the spinal process. In the cervical spine, you do have to be very generous undercutting the spinal process. In particular, in very severe stenosis cases, you cannot expose any pressure onto the spinal cord. You will have monitoring changes very quickly. And then you do the contralateral decompression. So that's a thing. And where is this useful? Well, here's an 84-year-old male, sick as an 84-year-old with lung cancer, other comorbidities, and he complained about unsteadiness and loss of dexterity. So maybe he couldn't use his hands anymore. And you can see what you can see on the X-rays there. I mean, this guy obviously has a thoracic kyphosis that he then corrects with hyperlordosis in his neck. So he has to lift up his neck in order to see something, and that causes then buckling of the L ligament. In a patient like that, obviously you would be insane to think about a deformity correction. He would have a peg and he would have complications. And that, for me, is the ideal patient where you make a gigantic difference for that. I just saw yesterday a patient like that too, that I'm not fixing her lumbar spine. She's also 80 plus. And these patients are not super happy, but because, you know, the neck pain and the discomfort is still there, but the myelopathy disappears. Um, and so here's a post-operative image. And one thing that really surprised me, how much space you generate. So we did a C2, C3, and C3, C4 decompression. You can see in the right lower panel here how much CSF you have around the spinal cord. And so the space that you create with this is tremendous anyhow, but I just want to point out one more time, you really can only use this when you have pathology from the back. So if somebody is straight or kyphotic and the main pathology is in the front, this is not going to help you, obviously. But a great procedure, and what a great way to help patients that really need help. And again, we had a talk right now before the thoracic discectomy, so I don't want to hammer that home. Again, same thing here, thoracic discectomy. We'll use the caudal SAP as a target area. Again, this is where we land with our Jamshini needle. The pedicle helps us to be oriented and avoids to do a lot of unnecessary X-rays. And you can see here the pedicle that you see during the procedure. And so here's the pedicle, here's the dura, here's the disc. And typically, again, I call it the Turi shot because in the US we have a lot of medical legal litigation. So every transfemoral case for me, I put up the kerosene onto the pedicle, onto the caudal pedicle. What it does is it orients you in all three dimensions, because there's no way it can be off. Once you've seen the pedicle, you know where ventral is, dorsal, medial, lateral. It really is a solid anchor. It can do the discectomy, and then this is a case I wanted to present to you, last case, and I'm almost done here. Again, thank you for being so flexible. So here, this is the cases that, you know, like nobody wants to see because they're complex and they are, you know, that's not something you want to see in your private practice. But I have the university, that's what I see. So 45-year-old, morbidly obese, BMI of 60, ankylosing spondylitis. Here you can see her standing in my office, the sweetest, nicest lady ever. And you can see on a t-shirt, she's dripping CSF out of her back. She has had a T11L1 arthrodesis, an open decompression at the outside hospital. Patient developed a non-union chronic CSF leak. And had multiple revisions. She had like 4 or 5 revisions by plastic surgeons trying to kind of take care of this wound that was leaping CSF. Really no success with that. She had low extremity pain at 8 out of 10, was severely disabled with an ODI of 50. As you can see, a kyphotic posture, only able to stand with assistance. So she's holding on there. She needs to walk or to ambulate. However, her strength at that point was intact, and she had a sensory level at that level. And so you can see on the imaging, so she has totally she has basically a Charcot joint there, large osteophytes, the pedicles are gigantic, and there's very, very little space for the spinal cord given those severe degenerative changes. And so in her, so we did a transforaminal discectomy, right, partial T12 corpectomy. So we really removed a large part of the T12 pedicle. And again, I agree that, you know, doing this via 3.7 millimeters is obviously challenging and takes time. But here's some of the bone removal that I just wanted to show. And one thing that you can see here is here's the ventral osteophyte here. The spinal cord starts here. Interestingly, and not unexpectedly, there was a large dural defect that kept the leak open. We found the leaflet of the dura, and you can see that. So that's all open. Here's the dural sleeve. And all this, the dura is gone. So you're looking at spinal cord itself here right now. And so we are removing part of the T12 vertebral body for the corpectomy. And you can see, so this is really almost like intradural sort of work here. So again, spinal cord is there. The dura stops here. Again, from this Charcot joint, it's just totally eroded. And you can see here nerve roots and everything. And so we close it typically with a piece of Duragen, and you can see here, so putting a piece of Duragen in there, but people use different stuff, so I don't want to there's different ways to, secure that. So you put that in there. This is a little technique that I like to do. Is you guys see the needle coming in on the side? I like to use the irrigation channel as my second hand for these closures. And take a K-wire and you go through the irrigation channel, and then you can stabilize something. And basically it allows you to do manual work. And typically when you have to do something like that, I use, again, here's in the irrigation channel, we have a K-wire coming through, and you can stabilize the piece of foam, the urchin, hold it there in place with that, and now we come down there and we secure it with some glue. So now we come back in here and put some glue in there, and secure that repair. And this is the imaging afterwards. So you see preoperative, you can see all the osteophytes and that were resected there on the CT scan. You can see it nicely there. And then you can see that we resected the pedicle there and the part of the vertebral body. So we did extensive bone work, combined it with an endoscopic T-lift. So we put a graft in there endoscopically. That was not without complications. So this patient developed a pneumothorax, which I never had with a thoracic disc. So that's maybe something for everybody who's doing thoracic cases. I don't know, it was because of the Charcot joint and everything was communicating, but she developed a pneumothorax, so she needed a chest tube. She did have some issues with her strength, so she has like a 3 out of 5, but she's not able to stand and ambulate again. Her CSF leaks subsided, and she was able to successfully go home. And we combined it obviously posterolateral instrumentation. Again, a very difficult case with no perfect outcome, but I think the endoscopic technique really helps with these very, very complicated patients to offer them treatment. And that brings me to the conclusions. I think the technology for full endoscopic spine surgery is rapidly evolving, as we've seen in other talks too. There's a lot of good people and brilliant surgeon, working in this field and making it better. I hope that the common nomenclature system that we worked for over a year on is going to be used and helps us to put this field on a stronger foundation. Again, it's going to be resulting in more literature and better science and a faster development if we can all talk the same language. And again, it's same for me. I've 10, 15 papers that I didn't use that same nomenclature system, but I think we have to move along and sort of make those updates. The procedural protocols that we developed, the AO, I think they help us to standardize surgical techniques. And full endoscopic approaches now with those modern tools allow for safe and efficient decompression surgeries of the entire spine. And I think future advances of tools is going to be navigation or any other technology that helps us to get the CM out of the OR. The fusion surgeries, I think, which will be the next big frontier. And that gets me to the last slide. Thank you so much for inviting me. I really, again, apologize for the time confusion, even though you provided this brilliant sheet of time zones. Somehow I got it wrong. Here's, a lot of these things we were able to write up in a textbook that I think is very helpful to teach residents and fellows, so they typically bring it to the OR and it helps. So any suggestions also how to make this book better for us is very welcome. And here, if there's any questions, then I'm happy to answer them. Thank you so much.
Dr. Hofstetter, first of all, welcome. Wonderful lecture by you. I think two major take-homes from your lecture for all of us is the introduction of navigation in endoscopic spine surgery. So I think that definitely is going to help decrease the radiation exposure that an endoscopic spine surgeon goes through. And I think that's a wonderful innovation that we all should look forward to. The second major thing that is a take-home message for all of us is the common nomenclature that AO Spine is working upon introducing. It should help clear up a lot of air and definitely make research and publications much more organized. So you being part of that effort, thank you very much. We had a wonderful presentation by you. We really appreciated your presentation on the thoracic spine with the CSF leak. That was a very wonderful presentation by you. I think all in all, we've had a very good day with all the panelists. I wish to thank all the panelists who have been present with us. Dr. Sameh, thank you so much. You have been the tiger force, the person who has pushed me consistently in doing this job. And Dr. Anand, and I'd like to thank Dr. John Bennett also, Neurosurgical TV. I would like to end today's session and hope to see you all again tomorrow morning at 11 o'clock Indian Standard Time. We have some very, very beautiful presentations tomorrow. And I hope we have a good day tomorrow again. Dr. Hofstetter, pleasure having you with us once again. Thank you so much for being with us.
Yeah, no, thank you. What